to very briefly introduce our panelists, and then we'll get right to it. Today we are going to hear from Dr. Thomas Cornwell, the founder and chief executive officer of the Home-Centered Care Institute.
Thanks so much to the Alliance, as well as to the sponsors, for allowing me to speak today on aging in America. Is home-based primary care too good to be true? And I want to start with the story of Elsa, who was born in Germany in 1921. I was called up by social services that you heard about from Mr. Robertson to see her because of multiple hospitalizations. She'd had over 10 in the prior 6 months for things like her heart failure, diabetes. She had pressure sores because she was always in a wheelchair. She had peripheral vascular disease that you can see because of her amputations. And because of all these admissions, the hospital said to her, "You are no longer able to care for yourself. You have to go to a nursing home." Well, she refused, and I was called out by social services, and what I learned on my first visit was that part of the reason why she had these amputations was because of damage done by the cold winters in a Nazi prison camp. She was also not able to have children because of what happened in that prison camp, so she had no one to care for her. While bringing her quality home-based primary care, she couldn't even get out to a doctor between the hospitalizations because her home was not handicap accessible. And so we brought great primary care to this patient. We got her diabetes under control. We got her heart failure under control with the help of home health and getting her a hospital bed so she didn't have to sleep in her wheelchair. We were able to heal her pressure sores. She got so much better that we were actually able to arrange for her to go to outpatient rehab and get new prostheses so that she could actually walk again, get out of the hospital some, and for the first time get into her bathroom that she wasn't able to with her wheelchair. Over the next 8 years, she only had 2 hospitalizations, and throughout her care, we worked with social services as well as home health. It really takes a village, as you heard, to take care of these complex patients. You heard about that by Mr. Robertson, and you're going to hear about it from our other speakers. But I see outcomes like this all the time, that the sickest patients in society are not getting the primary care that they need, and we bring it to them. We improve their quality of life. We improve the quality of life for their caregivers, which is a whole nother topic. But we also reduce healthcare costs by enabling them to age at home and avoid hospitals and nursing homes. One of the things I just want to emphasize is home-based primary care is quality primary care, high-touch primary care done by doctors, nurse practitioners, and physician assistants. But we now have high-tech capability. On my cell phone, within 30 seconds, I can get an EKG. There's apps for doing things like vision testing, medication databases. We can do portable lab tests in the home, as well as draw blood in the home and spin it in our car with portable centrifuges that plug into your cigarette lighter. X-rays and ultrasounds can be done in the home. And so while this is high-touch primary care, we do have the high-tech capability of truly doing quality primary care in the home. And Sabrina is going to be talking about telehealth, that the future is just going to be so much more impactful as we incorporate that into home-based primary care. So I gave you an anecdotal story of the incredible value of this, but we also have good data. And the initial data that really impacted our nation came from the VA's home-based primary care program. The home-based primary care program is the largest program in the country. It's in all 50 states. In addition to home health and hospice, they send out doctors and nurse practitioners, mental health workers, social workers, and they have pharmacists on their teams to really surround these veterans with great care. But that great care costs $11,000 more in the home. And about 13 years ago, the VA was told you need to cut the program. You're spending 460% more than usual care. Tom Eads, who's been a champion of home-based primary care and other things in the Veterans Administration, asked his superiors for some time to look at all the cost data. They went back to 2002, and I think what they found even surprised Dr. Eads. They found an 87% reduction in the use of nursing home, 87%, 63% reduction in hospital costs, an overall savings of $9,000 per veteran. And when you multiply that by the 11,334 vets in the program, it came out to $103 million savings by doing what the veterans wanted, giving them more care in the home. It also has the highest patient satisfaction. And so, with this being so wonderful, why isn't it more prevalent? Is it too good to be true? And the reason why it is not more prevalent, the main reason is fee-for-service. And you heard again from Mr. Robertson that we have this fee-for-service system that rewards volume, not results. And house calls is a very low volume but high value service. And we have seen now Medicare is aligning payments to enable aging in America at home. The Independence at Home legislation is one of the examples where it had great outcomes, and in the first 2 years saved $33 million on about 15,000 patients. And we have now taken that learning from Independence at Home, which has been extended now another 2 years, and have proposed a new complex chronic care track that's a part of the Comprehensive Primary Care Plus program. We can maybe discuss that more if you haven't heard of it, but it's a large Medicare demo of about 2 million patients, but a new complex care track that would target these high-cost disabled or chronic illness patients. It would provide payments that would support this care, but also had shared savings and take on risk. There would be flexibility in the terms of waivers for site of care, for doing innovative telehealth that we're going to hear about, but also some flexibility with nurse practitioners and physician assistants to allow them to order home health. And finally, it would incentivize quality and outcomes so that the cost savings could actually be a part of paying for the program. So I really appreciate the people in this room and the organizations. For me personally, Health is Primary has been so supportive of the Independence Home and home-based primary care, along with others in the room, and I look forward to working with you and to advance home-based primary care, as well as age-friendly communities in our country. So thank you so much.
Well, thank you. This is a terrific panel. We have time now. We have about 15 minutes left in the briefing, time for some Q&A. So I want to invite anyone who has a question to stand at the mic or hand your green card to one of our staff members. And while you're kicking it off, I want to bring up the role of Medicaid, because we haven't had that conversation. We've talked about long-term services and supports. The Medicaid program has for some time sort of been involved in this rebalancing, this effort to move from nursing home to home and community-based services. So I want to ask the panel, can you talk, and maybe I'll start with Tom, can you talk a little bit about how can these efforts that you're talking about kind of support the Medicaid efforts to transition to HCBS?
That's a great example because it really shows the impact that policy can have on aging at home. I've been doing this long enough that I know in 1983, if you needed help with long-term support and services, 1% of the dollars went to home and community-based services, 99% went to nursing home care. So basically you had one option, nursing home. That has steadily reversed over the years, in part because of money follows the patient. But I think the latest data in 2017 was that 57% now goes to home and community services, some of the things you heard about Mr. Robertson, and 43% goes to nursing home. And the problem with that is, as we are literally taking patients with money follows the patient out of nursing homes and putting them into the home, they then don't have the care if they can't get to the doctor's office. And so we have to give them more than just the home and the support. We also need to get the health care in there.
We have a lot of healthcare leaders here in the audience, and there has been a lot of talk about kind of that need to move beyond healthcare and address these so-called social determinants of health. So, I mean, how can the healthcare system kind of do a better job? Like, what are the limits and what are the possibilities?
And that is where I think anyone going to the home, not necessarily a doctor, but a nurse or a handy person. I had a patient that had been having chronic leg wounds. And when I finally did a house call to her, there was 2 to 4 feet of garbage everywhere in her apartment and no place to even lie down, which is why her legs were swollen all the time. And so again, seeing it obviously can really help in terms of seeing the refrigerator. Is it empty? Is there of food scarcity, and obviously going to the home can help you with that.
Thank you. We have a question at the mic. If you could introduce yourself and ask your question.
Hi, Shauna Koss. I'm with LivePAC, which is a platform for caregivers and their families. But I'm really building on this conversation, which is if social determinants are driving anywhere from 60 to 80%, we definitely want to see collaboration, but is there a risk in medicalizing or embracing these activities as part of the medical model as opposed to really not only investment streams, but really a shift consistent with all the other developing countries of full investment on social services and community-based needs. Perhaps one of the models that's most interesting is as we see mergers that impact certain communities, taking a portion of those mergers, and these have been voluntary, but potentially it could be incentivized to invest in the communities that are impacted, and not in the health model, but in the community-based services model.
Yeah, and I just like to say that when we started the Home-Centered Care Institute to advance home-based primary care, we could have called it anything. We could have called it the House Call Institute, the Home-Based Primary Care. We called it the Home-Centered Care Institute because we are a small part of what is needed. We've been missing. We haven't been to the table. And so I completely agree with you that in everything that has been said, but the problem is that these are the sickest patients in society that are homebound. They need that component, but we need to put significant dollars into supporting them being there. And it's not a medical model, it's a social model. Mm-hmm. It is a social model to keep them home, not a medical model.
Yes. I couldn't agree more. I mean, I think that moving away.
We have a question on the a card that I just want to get to before we wrap up, which is it's a question for Dr. Cornwell, but open to the panel, which is, could you speak a little bit more to the chronic care track of the Independence at Home program, and perhaps that's a question about the CPC Plus piece that you talked about. Could you kind of say a little bit more about kind of where we are with that and where it might be going?
Right, and maybe Eric and Ray, can you just stand up a second? Because Ray actually was part of the one that actually wrote what was presented to CMS. And so CMS is very interested in what these two have been working on along with a group of us. But again, it's taking the learning. Eric DeYoung is the president of the American Academy of Home Care Medicine. He has been the chair of the Public Policy Committee that has taken, and he is an IAH practice, one of the 15. And so he has a ton of experience, and he's taken the learning along with Hellsperian to create this. And why don't you I'll stop talking because it really, you guys are the ones.
Thank you, Tom. And thanks to the panel and Sarah for a great panel. So the CPC Plus track that CMS is working on right now in CMMI, which the Academy has helped provide some input on and provide a framework, is basically an idea of rewarding team-based primary care, rewarding medical services, but also social services and a whole interdisciplinary team, and giving enough money, frankly, to grow primary care for the most sick, complex elders in Medicare. And it would be a new payment model, which is kind of learned from IAH, but involves PMPM plus some flat fee, perhaps, for visits, plus shared savings. So it's rewarding results for practices that are willing to take on the most sick, most complex patients in Medicare and do good primary care at home or from the office, but as long as it's team-based care that keeps folks where they want to live. And Ray has helped kind of devise the structure of that CPC Plus framework that we are working on with CMS, so he may have one or two words to add.
The only thing I'll add is that it also includes voluntary alignment from patients, and the other piece that's important is the quality aspect, which is extremely important. The quality measures that are included, which we've been working very closely with CMMI on, which is important, and also came from the learnings of Independence at Home.
Great, thank you. So,
Sir, can I just add, the number one quality measure we decided to propose was % of days spent at home. Mm-hmm. That's what we're proposing to CMS as the number one quality measure.
Thank you. So we are unfortunately out of time, and I think we could talk about this for another couple of hours probably. But I want to just ask each of the panelists if you could just to take just to take like 30 seconds to say, you know, kind of if there's one thing that you hope that policymakers kind of take away from this conversation, what would that be?
There's one of your resources is something called the Perfect Storm, and it really goes over, it's just 7 pages that goes over the data on both the CPC Plus program as well as the advantages to home health, or home-based primary care. But one of them that we discussed a little bit was just 25% of Medicare dollars goes to costs in the last year of life. And that's another huge thing, that home-based primary care sees these patients way upstream. About 25% of our patients die a year, 75% die at home. 74% are on hospice much longer than the national average. And so that's just another aspect that we didn't talk about, but it's not just aging at home, it's actually also dying at home, if that is your wish.
Well, thank you so much to all of our panelists. Thank you once again to those who have supported today's event and the entire series. Thanks to all of you for being part of the Alliance audience, and I wish everybody a happy holiday season and healthy. Thank you.